Hey everyone, welcome to another week of AMP2. I hope you guys are getting excited because we are almost finished with the semester, all right? So we only have two more actual chapter lessons to go through, that being this week, chapter 24, the urinary system. But then also next week, we'll do chapter, I believe it's 25, with the male and female reproductive system. So we're almost finished. You guys have been doing great, and keeping the stamina for the semester. Trust me, I am very well aware how tough and exhausting AMP2 can be, but I applaud you all for hanging in there and for continuing to try your best to do well in this course. So, some overview for what's going on still in the course. Again, like this week, we'll have the urinary system. This week, the only things you guys have due are your quiz that'll be due on Sunday, and the lab that will be due on Sunday. So, make sure you look at the weekly overview document for those to know the specific information about, the quiz being open notes, the number of questions on the quiz, the amount of time you have. And then the lab this week, unfortunately, this is one of the labs that is really heavy for like in-person activity. And being that we're online, we can't really do that. So you'll get to watch a kidney dissection and kind of work through some problems that you would have done in person, but the labeling will be associated with that lab as well. Okay. So this week, urinary system, next week, reproductive system. After that, you have a week where, we'll be go through all the materials for the course, but you'll have your lab exam on the Wednesday. I believe that date is November 19th. Same dates and or same times as we're normally doing, the same room that we're normally in. So that'll be the day for your lab exam, and that'll just be over the different labs from the last lab exam. They won't include the previous materials for the labs. Um, you'll then have fall break, which I know you all are probably very excited to have a break in the semester. Probably as excited as I am. So the chance to recharge, kind of recover, and then be able to study for your final exam that comes the week after. Okay. So our final exam will be on December the 3rd. Okay. Same times as we always do. I've already assigned out the room for that time and date, or that date and times. So we're good to go there. Your final exam again is on December 3rd, 2025. As far as course materials left, in terms of grades, we don't have much left, so we're really getting really close to the end here. You have two quizzes left, two labs left, and then you have one writing assignment, the lab exam coming up, and then the final exam as well. Okay, so we're pretty much wrapping things up for AMP2. So, with that, we can go ahead and get into the lesson. As always, if you guys have any questions after the lesson or need anything from me, you know how to find me and get in touch with me. I'm happy to try to help you out with understanding what's going on and help you be successful in the remainder of this course. But yeah, let's get into it and let's finish strong with this AMP chapter 24 urinary system. So, let me stop staring at myself because I will get caught up on that. I want to then share the presentation, share it with you. I'm going to move this little box up to the corner so I'm not staring at myself again. And then I want to from the beginning. And we are ready to go. All right. So, as far as the lesson objectives for chapter 24 on the urinary system, pretty straightforward. I wish I had changed the order of them a little bit, but it's not that big of a deal. Um, the first objective is to basically describe the composition of urine. Okay, I would probably slide this one a little further down, but ultimately for this lesson, you guys will be labeling the structures of the urinary system, characterizing the roles of each of the different parts of the urinary system, illustrating how the macroscopic and microscopic structures of the kidney kind of influences its function. Trace the blood, flow of blood through the kidney. There's an entire diagram pathway of that. Outline how blood is filtered from the kidney nephron. Provide symptoms of things like kidney failure. Talk about some of the other diseases of the kidneys and urinary system as well. And then finally, to list some of the solutes filtered, secreted, and reabsorbed in the different parts of the nephron as well. Okay, so lots of things going on for the urinary system here. Now, We'll start by looking at the major functions of the kidney. And we really focus and highlight the kidney for this chapter because it is the primary, or they are, because there are two, the primary organs of the urinary system. Okay, so the kidneys are our major excretory organs. They're responsible for maintaining the body's internal environment, or homeostasis. First, the kidneys help to regulate total water volume and the total solute concentration in that water. So, in other words, they determine how much water stays in the body and how much is excreted, keeping our blood volume and osmolarity levels stable. Next, they help to regulate ion concentrations in the extracellular fluid. So things like sodium, potassium, calcium chloride, um, all of those different ions. Even a small imbalance in these ions can disrupt things like nerve signaling, muscle contraction, and overall cellular functions. So that's really important for our body's homeostatic balance. They also ensure long-term acid-base balance, so helping to maintain the proper pH of the blood by either conserving or excreting hydrogen and bicarbonate ions. This complements the faster acting respiratory system in controlling pH, which we talked about in a previous chapter. Of course, the kidneys are also key for excreting metabolic waste, toxins, and drugs. So basically, removing nitrogenous waste such as urea, creatinine, and uric acid from the bloodstream. They also have important endocrine functions as well. So if you recall back to the hormones that you learned about in the endocrine chapter, the kidneys produce erythropoietin, which stimulates red blood cell production in the bone marrow, and also renin, which helps to regulate blood pressure and fluid balance through the good old renin and angiotensin aldosterone system that you learned about. So, finally, the kidneys are also involved in activating vitamin D. The inactive form that we get from our diet or sunlight is converted by the kidneys into its active form called calcitriol, which is essential for calcium absorption and overall bone health. So, we also need to talk about the urinary system as a whole because it doesn't just include the kidneys. There's more than just that. The ureters transport urine from the kidneys to the urinary bladder, and that is where it's stored temporarily for a little while. And then it leaves the body through the urethra from the urinary bladder. Okay. So it's important to remember that while all these structures help make up the urinary system, it's really the kidneys that are performing a huge bulk of the work, the critical regulatory and excretory work that's associated with the urinary system. Now that we know what the kidneys do, let's take a look at where they are and what they look like. So, the kidneys are described as being retroperitoneal, meaning that they lie behind the peritoneal cavity. If you remember, that's the thin serous membrane that lines most of the abdominal organs. So they're located in the abdominal region, but they're not actually inside the peritoneal cavity itself. They sit posterior to it, kind of pressed against the back body wall. Um, they extend roughly from T12 to L5, so the upper parts of the kidneys are protected by the lower ribs. If you think about your own back, that puts them just below the rib cage, which is why trauma to the lower back can sometimes affect kidney function. Because of the position to the liver, the kidney sits slightly lower than the right kidney, at least sits a little lower than the left, usually by about like a centimeter or so. And that's just a consistent anatomical asymmetrical feature that you see in most people. And then sitting on top of each of the kidneys are the adrenal glands that you learned about earlier in the semester. And again, these are a separate organ. They are part of the endocrine system, not the urinary system, but they do share the same retroperitoneal space as the kidneys do. Now, each kidney has a convex lateral surface, so the outer curve, and a concave medial surface. That concave side contains the renal hilum, which is essentially the entry and exit point of all major structures. So things like the renal artery, the renal vein, the lymphatics, and the ureter. And if you look at it in a cross section, the hilum opens into the central space that's called the renal sinus, which houses the vessels, nerves, and fat that supports overall kidney, supports the kidney internally. So there on the slide, you see the word function. Basically here, remember that the external anatomy gives us important cues to the kidney's functional design. So that hilum, for example, is the critical gateway for blood filtration and urine drainage. The overall structure itself supports everything that we discussed on the previous slide. So basically maintaining blood chemistry by filtering and modifying the plasma that flows through it. So in short, the kidneys are retroperitoneal, asymmetrical, and highly vascular organs designed for this continuous, precise regulation of the body's internal environment. So now let's take a closer look at the kidney's protective coverings and its internal anatomy. Both of these are crucial for understanding how this particular organ functions. So each kidney is enclosed by three layers of tissues. Starting from the outside, we have the renal fascia, which is this thin but strong layer of dense connective tissue that anchors the kidney to the surrounding structures, particularly to the posterior abdominal wall and the peritoneum. This anchoring layer keeps the kidney stable and helps to maintain its position even as we move around and we breathe. Beneath that lies the pararenal fat capsule, which kind of acts like a cushion. So it helps to absorb like physical shocks and protects the delicate renal tissues from trauma. When this fat layer is depleted, such as when someone loses like extreme, like it has an extreme weight loss event or something, the kidney can actually drop to lower than normal, and this is a condition called renal ptosis, which can kink the ureter and block urine flow even. The innermost covering is the fibrous capsule. This is a thin, transparent layer of connective tissue that prevents the spread of infection to the kidney itself. So if there's an infection in the surrounding tissues, the capsule kind of acts as this protective barrier to contain it, which is extremely important for overall health in the body. So now looking inside the kidney, um, we can identify these three major regions. So the renal cortex is the outer lighter colored region. It sits uh, it's basically the site of the most blood filtration. Deep to that renal cortex is the renal medulla, which consists of renal pyramids. The renal pyramids are these cone-shaped masses of tissues with a striped appearance due to these parallel bundles of microscopic tubules. The tip or the papilla, the renal papilla, of each of these pyramids projects into a small collecting space. Between the pyramids are renal columns, which are inward extensions of the cortical tissue that separate and support the medullary pyramids. You also have lobes of your kidneys. So a lobe consists of one pyramid and its surrounding cortical tissue. Each kidney contains about 8 lobes on average. And at the center, is the renal pelvis, which is the funnel-shaped structure that collects urine. Okay. So the renal pelvis is continuous with the ureter, forming this direct pathway for urine to leave the kidney. So the pathway for urine flow follows this very clear sequence, being the renal pyramid to the minor calyx, to the major calyx, to the renal pelvis, to the ureter. So overall, these layers and internal structures all kind of work together to help protect the kidneys, to organize its filtration regions, and to help direct the flow of urine efficiently out of the organ and towards the urinary bladder. So I mentioned earlier that you'd have to learn about the blood vessels of the kidneys and how all that works. And because the kidneys cleanse the blood and adjust its composition, they need a very rich blood supply. In fact, if you think about it, about one-fourth of the body's resting cardiac output, that equates to about roughly 1.2 liters of blood per minute, actually flow through the kidneys. And that's pretty remarkable considering how small they are relative to the overall body size. But let's go ahead and walk through the pathway of blood flow through the kidneys, starting with the aorta. Okay. So, starting with the aorta, blood leaves the aorta through the renal arteries, one of those going to each of the kidneys. Because, again, remember, you have two kidneys unless something's happened and you've lost one. Um, each renal artery branches into segmental arteries, which enter the kidney at the hilum. From there, the segmental arteries divide into interlobar arteries, which travel up between the renal pyramids through the renal columns. At the base of each pyramid, these vessels branch out to form the arcuate arteries, which arc over the junction between the cortex and the medulla. Branching upward from those arcuate arteries are the cortical radiate arteries. These are also called the interlobular arteries. And these are just small arteries that extend into the cortex, delivering blood to the microscopic level. Okay. From the cortical radiate arteries, you then transition into the nephron-associated blood vessels. So the blood enters the afferent arterioles, each of which feeds into a glomerulus, which is just a tuft of these capillaries where filtration occurs. Blood that isn't filtered exits the glomerulus via the efferent arteriole. And what's unique here is that the arteriole doesn't immediately join a vein. Instead, it kind of branches into a secondary capillary network. So in cortical nephrons, we'll talk about the nephrons in a moment, but in cortical nephrons, that network is the peritubular capillaries, which surrounds the renal tubules and allows for reabsorption and secretion. In the juxtamedullary nephrons, though, the efferent arterioles form the vasa recta, which is just long, straight vessels that extend deep into the medulla, helping to maintain the osmotic gradient that allows us to concentrate urine. So, from these capillary beds, blood flows into cortical radiate veins, then arcuate veins, followed by the interlobular veins, and finally into the renal vein, which then exit the kidney at the hilum. The renal vein then drains directly into the inferior vena cava, returning that cleansed blood back to the systemic circulation. So, in summary, kind of make sure you're taking some time to walk through these different steps and learn what's going on with each of them. And know that this is just this very organized circulation path that allows the kidneys to filter, reabsorb, and fine-tune blood composition, our composition continuously, um, to, kind of help the body out and maintaining homeostasis. Now, now that we've covered the kidney's overall structure and blood flow, let's kind of zoom into its microscopic functional units, and these units are the nephrons. Nephrons are the structural and functional units of the kidney, meaning that basically every process involved in forming urine, so filtration, reabsorption, and secretion, happens within these tiny structures. Each kidney contains about 1 million nephrons, which gives the kidneys a tremendous capacity to filter and refine the blood. So, to give you some perspective, the two kidneys together can process around 180 liters of filtrate per day, although we only excrete only about 1 to 2 liters of as urine. The rest is reabsorbed back into the bloodstream. So each nephron has two main parts, the renal corpuscle and the renal tubule. The renal corpuscle is where the filtration begins. It consists of the glomerulus, again, tough capillaries, and the glomerular capsule, also known as the Bowman's capsule, which surrounds the glomerulus and collects the filtrate. And then from there, the filtrate passes into the renal tubule where it's modified as it travels. So water and solutes are reabsorbed, waste are secreted, and the final composition of urine begins to take shape. So we'll look at each of these components, the corpuscle and the tubule, in detail in the next couple of slides. But just for now, remember that every nephron acts kind of as this tiny processing plant that helps to fine-tune the blood's composition, the volume, and the pH, ensuring that the body maintains homeostasis at the cellular level. But before we do that, let's have a quick review. First question for you guys. What structure moves urine from the kidneys to the bladder? Hopefully you remember those are the ureters. Okay. So the ureters drain the urine from the kidneys to the bladder, and then from the bladder out the body is the urethra. Okay. Next up, what kidney structure prevents the spread of infections to the kidneys? Hopefully, remember that it's the renal and fibrous capsule. Okay, so this is again a thin but tough connective layer that wraps tightly around the kidney, serving as that protective barrier. So if there's an infection or inflammation in the surrounding tissues, it helps to contain it so that it doesn't reach the functional tissues of the kidneys themselves. Question three. Urine flows from the renal pyramids into the blank. Hopefully, you remember that is the minor calyx. Okay. So the papilla at the tip of each pyramid drains urine into the minor calyx, which then converges into the major calyxes, and then the renal pelvis, and then finally into the ureter. This is basically the beginning of the urine's journey out of the kidney. And then the fourth question here. What blood vessels feed into the glomerulus? Hopefully you remember that is the afferent arteriole. So it brings blood into the glomerulus under a relatively high pressure, which then drives filtration in that process. And then finally, oh geez, I can't see it because the thing's there. I think this question is, what capillary bed does the efferent arteriole feed into, if I'm remembering correctly? And hopefully you remember that being that it depends on the nephron type, but in general, we're talking about the peritubual capillaries and in the juxtamedullary nephrons, it's the vasa recta. Okay. So these capillaries are where most of the reabsorption and secretion takes place, helping to fine tune what will eventually become urine. Um, so, in summary, now that we've kind of built this solid foundation, we know the kidney's location, the layers, the internal structures, how blood flows through it, and the nephron's basic architecture. From there, we can kind of move on into how the nephrons actually filter and process blood, and through the different processes that are associated with that. So I mentioned we would talk about these more. We'll start with the renal corpuscle. Um, Again, this is the site where filtration actually begins. Okay, so the renal corpuscle has two main components. Again, those are the glomerulus and the glomerular capsule, also called the Bowman's capsule. Okay. So let's start with the glomerulus. It is again, the tuft of capillaries that sits within the capsule. These capillaries are made of fenestrated endothelium, which means that they contain these tiny pores or fenestrations in the vessel wall. This makes them highly porous, which allows for fluid and small solutes to pass out of the bloodstream while keeping blood cells and large proteins inside. Because of this structure, the glomerulus acts as a high efficiency filter. Okay. Surrounding the glomerulus is the glomerular or Bowman's capsule. It has two layers, the parietal layer and the visceral layer. The parietal layer is made up of simple squamous epithelial, which is these thin, flat cells that provide structural support but do not participate directly in filtration. The vascular layer, on the other hand, is made up of specialized cells called podocytes. And these have long branching foot processes that wrap around the capillaries. In between those foot processes are these narrow filtration slits. which allow fluid called filtrate to pass into the capsular space. That filtrate is essentially a plasma-derived fluid. It's similar to blood plasma, but without the large proteins or cells. And it will flow from the capsular space into the renal tubule, where it's further modified through reabsorption and secretion to ultimately become urine. So to summarize here, the glomerulus filters the blood through these fenestrated capillaries. The Bowman's capsule collects the filtrate, and together they form the renal corpuscle, which is the first step of urine formation. From there, after filtration occurs in the renal corpuscle, the resulting filtrate enters the renal tubule, where most of the real processing takes place. So this is where the kidney fine-tunes and the composition of that fluid, reclaiming what the body needs and secreting what it doesn't need. Okay. So the renal tubule has three major parts. The proximal convoluted tubule, or PCT. This is the proportion closest to the renal corpuscle that you see there in the diagram. It's basically located entirely in the renal cortex. The PTC is the primary site of reabsorption and secretion. So about 65% of the filtrate volume is reabsorbed there. And that includes water, glucose, amino acids, and ions like sodium, chloride, and bicarbonate. The cell linings in this tubule are densely packed with mitochondria to help power all of the active transport that's taking place there. And the PCT also performs secretion as well, so removing substances like hydrogen ions, ammonia, and certain drugs from the blood, and then adding them to the filtrate. You then have the nephron loop, or the loop of Henle, going on here. This part of the tubule dips down into the renal medulla and then comes back up to the cortex, forming this U shape, and that's what you see there in the diagram. It has two limbs. It has a descending limb and an ascending limb, and each has different permeability properties. So the descending limb is permeable to water, while the ascending limb is permeable to solutes like the sodium and the chloride, but not to water. Together, these differences establish this medullary osmotic gradient, which allows for the kidneys to produce either concentrated or diluted urine depending on the body's needs. You then have the DCT, which is the distal convoluted tubule. This section is farther from the renal corpuscle, but located in the cortex as well. The DCT is involved mostly in secretion, particularly of ions like potassium and hydrogen, as well as fine-tuning sodium and calcium balance under hormonal control. So by this stage, most of the major reabsorption has already occurred. The DCT just adjusts the final ionic composition of the filtrate. Um, Finally, multiple nephrons empty their DCTs into collecting ducts. The collecting duct plays a key role in final water balance and responding to hormones like ADH and aldosterone. And hopefully you remember that ADH is anti-diuretic hormone. Okay. So lots of things going on there. They receive filtrate from many nephrons, and they carry it through the medulla towards the renal papilla, where the urine is delivered into the minor calyxes. Okay. So in summary, I know that's a lot, but in summary, the proximal tubule handles the bulk of reabsorption. The loop creates the concentration gradient. The distal tubule fine-tunes the composition, and then the collecting ducts determine the final volume and concentration before the urine leaves the nephron system itself. Okay. So take some time again to wrap your head around what's going on in this section here and all of the different parts, because there are different key players happening in each of those parts. Okay. So let's finish the nephron pathway by looking at the collecting ducts a little more. Again, this is the final segment in a urine form the urine formation process. So, the collecting ducts receive the filtrate from many nephrons, meaning that multiple distal convoluted tubules form different nephron and from different nephrons all drain into a single duct. And these ducts run downward through the medulla, converging toward the papilla of each of the renal pyramids. And as they travel, these collecting ducts deliver urine through the papillae into the minor calyces, marking the point where the filtrate officially becomes urine. Okay, so it's no longer modified beyond this stage; it's urine. So now that, um, so now that the collecting ducts contain, it's important. How do I say this? It's important to know that the collecting ducts contain two major types of cells. Each of them have distinct functions. You have principal cells and intercalated cells. So the principal cells, these are the main regulators of water and sodium balance. They respond to hormones such as ADH and aldosterone. So, as a reminder, ADH increases water reabsorption by making the duct walls more permeable to water, concentrating the urine when the body needs to conserve water, and aldosterone increases sodium reabsorption and indirectly water reabsorption, which helps regulate blood volume and blood pressure. The intercalated cells, these are cells that are involved in maintaining the acid-base balance of the body or of the blood. So they can secrete hydrogen ions to correct acidosis or secrete bicarbonate ions to correct alkalosis, helping to stabilize blood pH over the long term. So the collecting ducts kind of act as this final checkpoint before urine exit the nephron system, adjusting the water volume, the ion concentration, and the pH in response to the body's current needs. Once the fluid passes through the papilla into the minor calyx, it's considered again urine at this point, and from there it flows into the renal pelvis, then to the ureter, and finally into the bladder for storage. So let's talk about the two main classes of nephrons found in the kidney. Even though all nephrons perform the same basic functions, which are again filtration, reabsorption, and secretion, their structure and location determine how they specialize in those different roles. So, um, first we have the cortical nephrons. These make up about 85% of all nephrons in the kidney. And as their name suggests, they're located primarily in the renal cortex, with only a small portion of their nephron loop dipping into the outer medulla. Because of this shallow position, cortical nephrons are mainly involved in basic filtration and reabsorption. So they do play a day-to-day role in um, work of cleaning up the blood and maintaining normal fluid balance. Their associated capillaries are the peritubular capillaries, which closely wrap around the tubules in the cortex for efficient exchange of materials as well. The second type is the juxtamedullary nephron. These nephrons have long nephron loops that extend deep into the renal medulla. Their structure is critical for producing a concentrated urine, especially when the body needs to conserve water. The long loops together with the vasa recta capillaries that parallel them, create and maintain the medullary osmotic gradient, that we talked about. And this mechanism allows for the kidneys to vary urine concentration depending on hydration status. Okay, so it's all about hydration in that regard. So in summary here, the cortical nephrons are the majority, the handling routine filtration in the cortex, while the juxtamedullary nephrons are specialized for water conservation. making them essential for when you're dehydrated or conserving fluid. And together, they allow for the kidneys to adapt fluid output to a wide range of conditions, from producing dilute urine after a long drink of water, to conserving like every drop when the fluids are scarce. So it can kind of fluctuate and it can change its function depending on what the body needs at any given point in time. So moving right along, we've talked about the nephron structure, but now let's look at the capillary networks that surround it. These are absolutely essential for filtration, reabsorption, and secretion. And again, those are the three key processes of urine formation. So each nephron is closely associated with two capillary beds. And in the case of the juxtamedullary nephrons, there's actually a third specialized set. So let's start with the glomerulus. Glomerulus is again the capillary bed. We talked about this a couple times now, but the capillary bed responsible for filtration. It's again the first step of urine formation. So what makes it unique is that it's both fed and drained by the arterioles, not the veins. The afferent arteriole brings blood into the glomerulus, while the efferent arteriole carries blood out. That arrangement helps to maintain this relatively high pressure inside the glomerulus, which is crucial for pushing plasma and solutes out of the blood and into the Bowman's capsule to form that filtrate that we've talked about. So once the blood leaves the glomerulus through the efferent arteriole, it enters the peritubular capillaries. These capillaries surround the renal tubules and cortical nephrons, and their main function is for reabsorption. So, reclaiming the water and solutes that were filtered, but the body still needs. Because the efferent arterioles has a smaller diameter, the pressure in the peritubular capillaries is low, which favors reabsorption rather than filtration. So these vessels are emptied into the small venules that return blood to the cortical radiate veins and eventually to the renal vein. Now, for the juxtamedullary nephrons, the efferent arterioles form a different network called the vasa recta. And again, the vasa recta are these long, straight capillaries that run parallel to the nephron loop deep in the medulla. The vasa recta are key to the concentration of urine, because they help to maintain the medullary osmotic gradient. So again, this is the difference in solute concentration that allows for the kidney to either conserve or excrete water. They act as these countercurrent exchangers, ensuring that the solutes stay in the medulla while the water moves in and out as needed. Now, in terms of kidney physiology, since we've now covered kidney anatomy and blood flow, we can look at how much these organs work every single day of our lives. So, the kidneys themselves are incredibly active. They process about 180 liters of fluid every 24 hours. And if you think about that, that's roughly half of an entire bathtub of plasma being filtered every hour. Um, which is crazy incredible in my opinion. Out of those 180 liters of filtrate, though, only about 1.5 liters leave the body every day as urine. So this means that less than 1% of the original filtrate is excreted and the rest is reabsorbed back into circulation. So your kidneys are constantly filtering, refining, and recycling nearly all the fluid that they handle. Together, though, the kidneys filter the entire plasma volume around 60 times per day. And that's an astounding level of processing for an organ that only weighs a few ounces. Um, because of all this filtration, reabsorption and secretion, the kidneys are metabolically very demanding. They consume about 20 to 25% of all oxygen used by the body at rest, second only to the heart and the brain in terms of oxygen requirements. This high oxygen demand supports the active transport mechanisms that move solutes and water across the nephron membranes, which is, really incredible. So before we go much further, again, let's just kind of clarify some of it might be a good place to clarify some terminology. So, because I'm not sure if I mentioned it or not, I just want to make sure that I say this. Uh, the fluid that first enters the nephron is called the filtrate. Okay. So it's essentially blood plasma minus the proteins. So everything small enough to pass through the filtration membrane, such as water, glucose, ions, and nitrogenous waste. And as that filtrate moves through the nephron, the kidneys selectively reabsorb what the body needs and secrete additional waste or excess ions. So by the time it reaches the end of the collecting duct, the fluid is no longer filtrate. At that point is where it becomes urine. Okay, and I do remember talking about this, but it's good to repeat it a couple times. The urine, though, consists and contains metabolic waste and unneeded substances such as urea, creatinine, uric acid, and excess ions or toxins that the body needs to eliminate. So it's another good place for a review. Before we move on, let's kind of pause and kind of make sure that the key ideas of the kidney anatomy and physiology are solidified here. So, first question, what part of the renal corpuscle filters out the blood? Hopefully you remember that is the glomerulus. So remember that it's a tuft of these fenestrated capillaries under high pressure. The glomerulus forces plasma and small solutes out through the filtration membrane into the Bowman's capsule, forming the initial filtrate. This is the very first step of urine formation. Second question, where does most reabsorption occur within the nephron? And hopefully you remember that's the PCT, and that PCT stands for the proximal convoluted tubule. Okay, so about two-thirds of the filtrate is reabsorbed there, including nearly all glucose, amino acids, and most ions in water. The PCT is packed with mitochondria to power all of this active transport. Third question, what type of nephron stays within the kidney cortex? And that answer is the cortical nephrons. They make up about 85% of all nephrons. They handle the bulk of the filtration and reabsorption near the kidney surface, while the juxtamedullary nephrons extend deeper into the medulla to help concentrate urine. And then finally, what is the kidney filtrate most similar to? And hopefully you remember that it is basically kind of like blood plasma minus the proteins. Okay. So at the glomerulus, the filtration membrane allows for water and small solutes to pass through, but retain larger molecules like plasma proteins and blood cells. So filtrate composition mirrors plasma just without those big proteins. Okay. So let's recap real quick. The glomerulus filters, the PCT reabsorbs, the cortical nephrons handle routine filtration, and filtrate begins as plasma stripped of proteins. Okay. So if you can connect those four ideas, you already have somewhat of an understanding of the essential structure function relationship that drives kidney physiology here. And then here too, this is just a diagram that I threw in here that kind of walks or kind of shows this process of these three major renal processes. So glomerular filtration, tubular reabsorption, and tubular secretion. And you can see where that's occurring in these colored arrows here. So here's your glomerular filtration, okay? Here's your tubular reabsorption and your tubular secretion going on. So just take some time, and this will help you with some of the structural labeling of some of those things that you need to do for this course. And then I also inserted this video in here as well that kind of helps with the urinary system. A lot of you have been asking, you've been studying a lot and you've been listening to my videos and you're still struggling a little bit. This is just an important reminder that like I'm not the only person who teaches A&P. Sometimes even whenever I was in undergrad, I would go and watch multiple professors teach the same concepts. We all pretty much use the same textbook. But um, you know, having a YouTube video that kind of like animates some of this really does help sometimes. So, here's a short video for you to watch of that process with the urinary system before we continue our journey with it in this lesson.
FanDuel, America's #1 sportsbook, just dropped
I
something
completely
big.
and totally forgot to
Picks. The
do
easiest
it
way.
without the ads, so hopefully it won't be bad.
Hi, it's Paul Anderson, and in this video, I'm going to go through the basics of the urinary system. The major organs in the urinary system are going to be the kidneys, and their major role is in waste excretion. They're cleaning our blood, and solid waste from the blood is eventually going to leave our body as urine. Now, in addition to doing that, they also regulate blood volume, blood pressure, blood pH. They regulate important electrolytes and metabolites in our body. The kidneys are incredibly important. Without them, you'll die unless you're hooked up to a kidney dialysis machine, but that's going to require going 3 times a week, 4 to 5 hours a day, hooked up to a machine just to clean your blood. Now, in addition to the kidneys, we also have other parts of the urinary system, including the ureter, the bladder, and the urethra. In males and females, the urinary system is essentially identical, except for the length of the urethra itself. Now, what's the role of the kidney? The role is to produce urine. From there, it's transported to the bladder through the ureters, and then from there, it's stored and eventually conducted into the environment. That's how we lose this waste. Now, you might be thinking to yourself, what is urine? Well, urine is mostly water, so 90 to 95% of urine is going to be water, but the rest of it is going to be solid waste, both inorganic and organic. Organic waste like urea, uric acid, and inorganics like toxins and certain salts as well. If we look at the structure of the kidney, on the outside, we're going to have the renal cortex. Renal simply means kidney. So we've got the outer layer of the kidney, and then on the inside, we have the renal medulla. And then on the center, we have the renal pelvis. This is going to be a hollow opening, and this is where all the nephrons are going to enter into. They're going to get rid of their urine, and that's eventually going to go through the ureter. Now, if we look inside the kidney itself, we find the whole thing is just filled with blood vessels. Around 20% of cardiac output is going through the kidneys. So that's a massive amount of blood that's going through the kidneys. How does it do that? Well, it comes in through the renal artery, out through the renal vein, but there's a huge amount of surface area inside the kidneys itself. From there, we go into smaller arteries, and then arterioles and capillaries, and then eventually the blood is going to come out. But the important waste excretion is going to take place as we get to those center blood vessels. So let's zoom into that, and let's zoom into the functional unit of the kidney, which is going to be the nephron. So if we look at where these blood vessels are found, blood's going to flow into the nephron through the afferent arteriole, and then it goes into the glomerulus or the glomerular capillaries. At this point, you essentially have a dead end. The blood is flowing in, and it comes to a dead end. That dead end is inside something called the Bowman's capsule. At this point, we're going to have filtration occurring. A lot of that blood plasma is squirting out of the capillary, and it's eventually going to move into the urinary system. From there, the blood goes through the afferent arteriole. And so at this point, we've got filtration taking place. This is where we're actually filtering the blood. Now, if you look at the blood vessels, they continue to go and wrap around the rest of the nephron, the peritubular capillaries, before they're eventually going to leave. What's going on all of this surface area is secretion and reabsorption. Secretion is when we're taking material that's in the blood that wasn't filtered out, but we're getting rid of that. And also there's some material in the filtrate, glucose, water, for example, that we want to reabsorb. So we're going to take that back into the circulatory system. So if we remove the circulatory system, now we can kind of see what that nephron looks like. First part's going to be the renal corpuscle right here. If we look at what's taking place there, that's where that filtration occurs. So at this point, we call this a filtrate. From there, it's going into a number of different renal tubules. The first one is going to be the proximal convoluted tubule. Proximal means close to the renal corpuscle. Convoluted means it's just folded over and over in many different dimensions. We're increasing the surface area there. What's going on at this place is that we're reabsorbing important material. We're reabsorbing solutes, water. We're taking that back into our circulatory system. From there, the renal tubules are going to flow down into what's called the loop of Henle. We have a descending limb of the loop of Henle, and during that, we're reabsorbing a lot of the water. And then as we have the ascending limb of the loop of Henle, we're reabsorbing a lot of that sodium and chloride, a lot of that salts are coming back into our body. If we look at where we are inside the kidney itself, As we go down into the loop of Henle, we've entered into that renal medulla. And if you think about what's going on as we move farther and farther down, we've set up a countercurrent exchange. What we're doing is we're increasing the salt levels as we move farther and farther down into that renal medulla. That makes it easier for us to take back more of that water in the descending limb of the loop of Henle and also in the collecting duct. From there, we're moving into the distal convoluted tubule and then into the collecting duct. If you think about where this collecting duct is going, you can see that we're getting a bunch of other nephrons that are connected to it as well. From here, it's eventually going into that center of the kidney, the renal pelvis, and eventually it's going to leave as urine. Now, what's going along in that distal convoluted tubule and the collecting duct is we have variable secretion and reabsorption of solutes and water. So in other words, sometimes we're getting rid of waste and sometimes we're taking that back into the body. Now, a lot of this is under hormone control. So for example, a really important hormone is vasopressin or ADH, antidiuretic hormone. And what that's going to do is it's going to affect the distal convoluted tubule and the collecting duct itself. And what it does is it essentially shuts down the flow of water outside our body. And so we can get a signal if we sense how much water there is in our blood, we can get a signal that means we have to hold on to that. Or we can have a signal that says we want to release that water and it's eventually going to leave as urine. If we look at where it goes, from here, all of that waste that comes out of the nephron is emptying out eventually into the pelvis, into the ureter, and it's stored in the bladder itself. From there, we can eventually conduct that to the environment. And so that's how the urinary system works. It's really simple. It's also really, really important, and I hope that was helpful.
So again, hopefully that was helpful. Just to kind of show you guys, like as a reminder, um, again, everyone keeps asking, how do I study? How do I study? Sometimes going to these helpful YouTube videos and seeing it taught in a slightly different way can certainly help. Same exact things that I just talked about in my lesson, but just kind of described in a very similar way. And in this case, it's kind of fast. All right. So moving right along for us. Next we can talk about urine formation. So here, urine formation occurs through three key processes within the nephron and the collecting ducts. So, glomerular filtration occurs in the renal corpuscle and produces the filtrate. The blood pressure forces the plasma and small solutes out of the glomerulus into the Bowman's capsule. You then have tubular reabsorption. This happens primarily in that PCT and other parts of the tubule. Here, the substances move from the filtration back into the blood, reclaiming the water, ions, and nutrients that the body needs. And then you also have the tubular secretion. This is the reverse process. So materials move from the blood into the filtrate, adding water, excess ions, and drugs before excretion. So together, these steps all filter, refine, and again finalize what is becoming urine, maintaining homeostasis of water, electrolytes, and pH. So the first step of that, kind of go into more detail, is a glomerular filtration. It's important to note that this is a passive process, meaning that no energy is required for this to take place. The hydrostatic pressure in the glomerulus forces the fluid and small solutes through the filtration membrane into the Bowman's capsule. So the filtration membrane again has three layers. The fenestrated endothelium allows most of the solutes and water through. The basement membrane blocks most of the proteins, and then the podocyte foot processes we talked about with the filtration slits provide final selective barriers. This allows for water, glucose, amino acids, and nitrogenous waste to pass into the filtrate, but the plasma proteins stay in the blood. So it's essential to kind of keep these keeping this is essential because it helps to keep proteins um how do I say this? Keeping the proteins helps to maintain colloid osmotic pressure and prevents loss of excess water into that filtrate. So it's important to note that no reabsorption occurs here. This is strictly a filtration driven pressure or filtration driven by pressure. Um, The filtration at the glomerulus again depends on the balance of outward and inward pressures. The main outward pressure is the hydrostatic pressure in the glomerular capillaries. Essentially, the glomerular blood pressure, which is about 55 millimeters mercury, this is the pressure that pushes water and solutes out of the blood into the capsule. So, two inward pressures oppose filtration. The hydrostatic pressure in the capsular space is about 15 millimeter mercury, caused by the fluid already in the capsule resisting more filtrate entry, and then also the colloid osmotic pressure in the capillaries, which is about 30 millimeter mercury. This is the pull of plasma proteins trying to keep the water in the bloodstream. So when you add these up, 55 millimeter mercury pushing out minus the 15 and the 30 millimeter mercury that are opposing equals about 10 millimeter mercury net filtration pressure. And we denote this as NFP, net filtration pressure. That 10 millimeter mercury net outward force is what drives the filtrate formation. Okay. So it's the effective pressure that causes filtration at the glomerulus. Ooh, okay. So why do we care about all these pressures in the glomerulus? It's because that NFP directly determines the glomerular filtration rate, or the GFR. Okay, so GFR is the volume of filtrate formed each minute by both kidneys combined. And normally this is about 120 to 125 milliliters per minute, which adds up to roughly 180 liters per day. Maintaining a constant GFR is critical. If that GFR drops too low, the kidneys can't make enough filtrate and the waste builds up in the blood. If it's too high, on the other hand, the substances that should be reabsorbed, like water and electrolytes, are lost in the urine. So that's not good either. A stable GFR allows ultimately for the kidneys to regulate the blood composition. It helps to maintain the extracellular fluid balance and blood pressure. So here's the key relationship. If you have an increased GFR, you have an increased urine output, which equates to a lower blood volume and lower blood pressure. And the reverse of that is also true. So a decreased GFR conserves water and raises blood pressure. So pressure at the glomerulus isn't just about filtration, it also has a direct link between kidney function and cardiovascular homeostasis as well in terms of blood pressure. After filtration, the next step is tubular reabsorption. And this is the process that quickly reclaims useful substances from the filtrate and returns them back to the blood. So the key player here is sodium, and this is the most abundant cation in the filtrate. Sodium is actively pumped out of the tubular cells by the sodium potassium ATPase pump, which moves potassium or moves sodium into the interstitial space. This active transport drives most other forms of reabsorption. It creates this electrochemical gradients that pull other ions and water along with it. So as sodium leaves the filtrate, water flows by osmosis, moving through protein channels called aquaporins. This passive water movement increases the solute concentration in the remaining filtrate. And because of that gradient, other solutes like chloride, potassium, bicarbonate, and even urea follow the water into the peritubular capillaries. So, in short, here, sodium drives the process, water follows by osmosis, and other solutes move along the gradient, all to ensure that valuable materials are reclaimed instead of being lost in the urine. Uh, So let's review how reabsorption varies across the different parts of the nephron. Starting with the proximal convoluted tubule, again, this is the PCT. This is the site of most reabsorption. Here, all nutrients like glucose and amino acids are reclaimed. About 65% of sodium and water are also reabsorbed here, along with many ions, most uric acid, and some urea. The PCT does the heavy lifting for the most part. It's where the majority of the filtrate is processed back into useful components. Next is the nephron loop, or the loop of Henle again. It has two distinct limbs with the opposite permeability properties. So, in the descending limb, water can leave, but solutes cannot. And then in the ascending limb, the situation reverses. So, water cannot leave and the solutes can. And this countercurrent movement establishes that osmotic gradient in the medulla that allows the kidneys to concentrate urine later. And then finally, you have the DCT, which is the distal convoluted tubule, and the collecting ducts that handle the final adjustments. So their activity is regulated by antidiuretic hormone or ADH, released by the posterior pituitary gland. And when the ADH levels rise, the walls of the collecting ducts become more permeable to water through the aquaporins, resulting in increased water reabsorption and more concentrated urine in the process. So overall, the PCT reabsorbs most substances. The nephron loop creates the concentration gradient, and the DCT and collecting ducts fine-tune water balance under hormonal control with ADH. And then the final step in urine formation is tubular secretion, essentially reabsorption in reverse. So it occurs almost entirely in the proximal convoluted tubule, though parts of the distal tubules and collecting ducts also participate. Uh, During secretion, secreted substances move from the peritubular capillaries into the filtrate. This process helps clear the blood of materials that weren't filtered at the glomerulus, or that were passively reabsorbed earlier. So the key functions here include the disposing of drugs or toxins that are bound in the plasma protein that couldn't be filtered, eliminating waste like urea or uric acid that were reabsorbed by diffusion earlier, and removing excess potassium under the influence of aldosterone. So, aldosterone acts on the distal tubule and collecting ducts to conserve sodium and secrete potassium, which raises the blood pressure and helps maintain normal potassium levels. Tubular secretion also plays a major role in controlling blood pH. So it does this by adjusting how much hydrogen ions or bicarbonate ion is secreted into the urine. And the kidneys can correct acidosis or alkalosis and keep plasma pH in a narrow range with that. So overall, the secretion fine-tunes the composition of urine, helping to ensure waste products, excess ions and toxins are ultimately eliminated while maintaining this acid-base balance and proper electrolyte levels. So from there, we can kind of move into some of the more fun things, particularly the clinical aspect of this. Now that we know how healthy kidneys work, we can evaluate how we can look at how we evaluate their functions clinically and some of the diseases associated with that. So one of the simplest tests you can use is a urinalysis. It can reveal a lot about the kidney health and even detect diseases or illegal substances. So this is a urine test, right? By examining the urine's composition, things like color, pH, proteins, glucose or cellular content, clinicians can help to identify things like infections, kidney disease, or metabolic problems, such as diabetes to access or to assess renal function more precisely, both blood and urine tests are used combined together to get a better picture of what's going on. Sometimes we can measure nitrogenous waste in the blood alone, such as blood urea nitrogen, which is BUN. or creatinine levels to get a quick estimate of kidney performance. Elevated levels suggest that the kidneys aren't filtering efficiently. However, to determine things like renal clearance, which measures how effectively the kidneys remove a specific substance from the blood, we do need both the blood and the urine samples. And clearance tests provide a more accurate measure of GFR as well and overall kidney efficiency. So, kind of to build upon some of this, renal clearance is the volume of plasma the kidney can completely clear of a particular substance in a given time. And it's a key tool for assessing kidney function. So by comparing concentrations of substances in the blood and urine, we can estimate the glomerular filtration rates, or the GFR, and detect glomerular damage, and monitor the process of, or the progress of these different renal diseases. So in chronic renal disease, the GFR drops below 60 milliliters per minute for at least 3 months. When that happens, filtrate formation decreases, nitrogenous waste build up, and the blood pH becomes more acidic. And the most common causes of this are things like diabetes, mellitus, and hypertension, both of which place long-term strain on the kidneys themselves. Renal failure is the most severe stage, and this is where you get into a GFR that falls below 15 milliliters per minute. This leads to uremia, which is a dangerous condition involving ionic and hormonal imbalances, um, metabolic abnormalities, and accumulation of toxic molecules in the blood. Symptoms of this include things like fatigue, loss of appetite, nausea, confusion, and muscle cramps, as waste products affect multiple organ systems from that. Treatment options here include hemodialysis, which filters the blood artificially, or a kidney transplant for long-term recovery. So so ultimately, kind of wrap this slide up, renal clearance testing not only measures kidney performance, but also helps to detect early damage and track disease progression before failure occurs from that. Um, Now we can also talk about exactly what is urine, because if we're using urine for some of these tests, we need to understand what urine can also tell us. So urine is about 95% water, 5% solutes, and mostly this is waste products and dissolved ions. The major nitrogenous waste associated with this include urea, uric acid, and creatinine. So urea is the largest solute component. It's produced from amino acid breakdown. Uric acid is a byproduct of nucleic acid metabolism, and creatinine is formed from creatine phosphate in muscle tissues. So these wastes all contain nitrogen, and they're the body's way for safely eliminating toxic byproducts of protein and nucleic acid metabolism. We can also look at color to really get an idea of what's going on with excretion function as well. So normal urine ranges from a pale to deep yellow due to the pigment urochrome, which comes from hemoglobin breakdown. Clear urine is normal. Cloudy urine is abnormal and may indicate things like a UTI, and that's a urinary tract infection. There are other abnormal colors too, like pink, brown, smoky. This could result from certain foods, bile pigments, blood, or even drugs in the system. So over in this diagram, you can kind of see some of these different colors and kind of get an idea of what may or may not be happening in association with the color that a patient is seeing in their urine. Um, so urine has several other characteristics that can tell us a lot about body chemistry and health as well. The first being odor. So fresh urine is only mildly aromatic, But if it sits, bacteria begin to metabolize urea into ammonia, giving it that strong, distinctive urine smell. Certain diseases, foods, and drugs can also alter urine odor as well. Um, for example, a sweet or fruity smell may suggest diabetes due to ketone bodies, while certain foods like asparagus or antibiotics can actually cause these very distinct scents. If you eat asparagus, you know what I'm talking about. And if you don't eat asparagus, you should go eat some and see what we're talking about. Also pH um, is important. So normal urine is slightly acidic, averaging around a pH of 6. Okay. So diet has a major influence here. An acidic diet, so high in protein or whole grains, lowers the urine pH. And an alkaline diet, such as a vegetarian or dairy-rich diets, can raise pH. So, prolonging vomiting or urinary tract infections can also make urine more alkaline. So, there's lots of things that can go on here, but odor and pH together can kind of provide quick clinical cues as well, in addition to color, about metabolism, diet, and overall urinary health. So again, another good moment for a quick review session before we finish the last stretch and kind of move from the kidneys out. First question, what happens in the glomerulus? So hopefully you remember this is where filtrate is produced from blood. Plasma and small solutes are forced out under pressure and begin urine formation. Second question, what's the most abundant cation in the filtrate? Hopefully you remember that is sodium, okay? It drives nearly all the reabsorption and secretion processes throughout the nephron. Next question, what nitrogenous waste comes from amino acid breakdown? Hopefully you remember that's urea, the main nitrogen containing waste product in urine. And then finally, what is a normal pH for urine? And hopefully, because we just talked about it, you remember that is 6. And that means that a pH of 6 is slightly acidic under normal conditions. So simple but important. All of these questions kind of build on the foundation of facts for how the kidneys are working and the clinical components of the kidney function altogether. So, literally moving right along with the urine. Once urine is formed, it's transported from the kidneys to the bladder through these tubes called the ureters. Okay, so each ureter enters the base of the bladder through the posterior wall, creating a natural one-way valve. So as bladder pressure increases during filling, the distal ends of the ureter closes, preventing this backflow of urine, and this helps to protect the kidneys from infection or damage as well. So the ureters have a muscular layer that propels urine by peristalsis. If you recall back to the digestive chapter, you remember that term. And again, this is just that rhythmic contractions that move urine towards the bladder, even if you're lying down or upside down. So urine transport is this active, regulated process. It's not just gravity driven, moving from your kidneys down to your bladder. Um, so again, the bladder is all about storing urine. So the urinary bladder is a retroperitoneal organ that sits on the pelvic floor, just posterior to the pubic symphysis. In males, the prostate lies just below the bladder neck, and in females, the bladder sits anterior to the vagina and the uterus. On the internal floor of the bladder is the trigone. This is a smooth triangular region defined by the openings for the two ureters and the urethra. This area is clinically important because it's especially susceptible to infections such as cystitis. When the bladder is empty, it collapses and the rugae, which are just folds in the mucosa, begin to appear. And as it fills, those rugae will flatten out and allowing for the bladder to expand without much rise in pressure. A moderately full bladder is about 20 centimeters long, holding about 500 milliliters. So that's roughly a pint. And it can temporarily hold up to twice that amount. But if, over distension can stretch or even burst the bladder, so it's not something that you want to happen. Um, so ultimately, the bladder is very flexible. It's a muscular reservoir designed for, um, the temporary storage of urine. So from there, urine moves again. From there, the move. Oh my God, how do I say this? From there, urine moves again, okay? And it moves out of the body through the urethra, okay? So the urethra is the tube that carries urine from the bladder to the outside of the body. At the junction of the bladder and the urethra is an internal urethral sphincter. It's made of smooth muscle, so it's involuntary. And when it contracts, it opens for the passage of urine to leave the bladder. Farther along, as the urethra passes through the pelvic floor, it's surrounded by external urethral sphincters. This one is a voluntary skeletal muscle, which gives us this conscious control over urination. So it is slightly different if as you're dealing with a urethra for a male versus a female. In females, the urethra is pretty short. It's only about 3 to 4 centimeters in length. Um, and the external urethra orifice is located anterior to the vaginal opening and posterior to the clitoris. In males, on the other hand, the urethra carries, it has a dual purpose in that it carries both semen and urine, serving as parts of both the urinary and the reproductive systems. And you will learn about the reproductive portion of this next week, for the last chapter. In males, though, it is much longer and it does pass through the prostate, the urogenital diaphragm, and the penis before opening at the external urethral orifice. So together, these sphincters and structures all ensure that urine flow is controlled. It is a one-way path from the bladder to the outside of the body. You don't want it going back the other way. So the process of urination is also called micturition. This is a coordinated reflex that requires three events to happen at the same time. So first, the detrusor muscles, the smooth muscle in the bladder wall, it must contract. This action is controlled by the autonomic nervous system or the ANS, specifically the parasympathetic stimulation. Second, the internal urethral sphincter must open, also under the ANS control, and this allows for urine to pass from the bladder into the urethra. And then third, the external urethral sphincter must relax. So this one is made of skeletal muscle and is controlled by the somatic nervous system, meaning that it's voluntary. We consciously decide when to release it under most circumstances. So micturition occurs only when these three actions together happen. So the detrusor contraction, internal opening, and external relaxation happen simultaneously with one another. And what this does is it allows for smooth, controlled emptying of the bladder itself. Um, so let's finish with some clinical issues. The first being urinary tract infections or UTIs. UTIs can occur when bacteria enter the urethra and multiply in the urinary tract. One simple cause from this is wiping from front to back after defecation, which can transfer intestinal bacteria, especially E. coli, towards the urethra opening. Females are more likely to get UTIs because their urethra is shorter and closer to the anus, giving bacteria a much shorter path to the bladder itself. In fact, about 40% of women, I'll need to check that statistic, but I'm pretty sure it's about 40% of women will experience a UTI at some point. In most cases, it occurs in sexually active women as well. And this is because during intercourse, bacteria can be pushed from the vaginal and exterior genital regions towards the bladder, increasing the risk for infection. So prevention often focuses more so on things like good hygiene, proper wiping direction, and emptying the bladder soon after intercourse to kind of help flush out any bacteria that may have been um, moved further up that system. There are several different types of urinary tract infections, depending on where that affection occurs. So you have things like urethritis, which is involves the urethra, cystitis, which affects the bladder, and pyelitis or pyelonephritis, refers to infection of the kidneys. And the kidney one is the most serious form. Common symptoms include dysuria, or painful urination, along with urinary urgency and frequency. So, feeling like you have to urinate over and over and over again. And when I say like have to urinate, I mean like you feel like you have to urinate, you go and you can't urinate. You just kind of drop a couple of drops of urine instead of actually emptying the bladder. Fever can also be associated with this. Also, you could have cloudy or blood-tinged urine as well. If the infection reaches the kidneys, patients may also experience back or flank pain due to inflammation in the renal tissues. There is some good news though, and it's that most UTIs can be effectively treated with antibiotics, especially if they're caught early. So, to kind of sum this up, the higher the infection travels up the urinary tract, the more severe the symptoms and potential complications, they increase as they move further up. But if caught early, they are able to be treated effectively, to help alleviate some of those symptoms. And there are also some drugs too, over-the-counter drugs that can be purchased to help with this as well. Um, Another clinical condition, one that is absolutely near and dear to my heart and life because I experience this one quite often, unfortunately, are kidney stones. Kidney stones have a couple of names. So another name for kidney stones is nephrolithiasis. We also call kidney stones renal calculi as well. But basically, kidney stones are hard deposits of minerals and salts that can form anywhere along the urinary tract. They typically develop when urine becomes concentrated, so causing minerals to crystallize and stick together. These stones can range in size from tiny grains to larger masses that ultimately obstruct urine flow, often causing very, very, very severe flank pain, nausea, and or even blood in your urine. Diet plays a big role here in stone formation. So eating foods that are high in protein, sodiums, and sugar can increase the risk, especially excess salts, which raise calcium levels and the filtrate and promote stone development as well. Um, Now, hydration and a balanced diet are key to preventative steps here. So if you dilute your urine, it keeps the minerals dissolved and helps reducing the chance of crystallization. Trust me, you do not want to have a kidney stone. Just to kind of give you guys a personal note, I had one earlier this semester. It actually put me in the hospital, or not earlier this semester, earlier this year. It actually put me in the hospital in January, early February. Had a massive ER bill from that, and had to go through lots of tests. And I think it took me a couple of months to actually pass the stone. The stone got stuck in my ureter and would cause pain as it kind of tumbled its way down, before, exiting my body. So. Definitely not something you want to encounter from a personal note. Stay hydrated, eat healthy foods, try your best to avoid kidney stones because there's definitely one you do not want to experience from a personal note. Okay. Well, with that, that is all I have for you guys this week with the urinary system. Okay, so remember, this is the second to last week of actual material that you guys have. Next week, we'll finish up our course with the reproductive system. You have two things due this week. You have your quiz on the urinary system, and you have your lab for the urinary system, both due on Sunday. So make sure you get those in as soon as you can so that you can have a breather before finishing up with the reproductive system and then your lab exam. It would also be a good point to note that you may want to go ahead and begin studying for that lab exam if you have not already begun to do so. Okay? Please, please, please do not wait until the last minute to do that. I really do not want you guys to fail that lab exam, especially when it is something that you can do really well on if you just study. Again, make sure you're looking over those labs, going through that lab structure list and making sure that you know how to properly spell and label those different anatomical structures. And in addition to that, knowing the different sections of the labs as well. Just because you did not take the course physically in person does not mean that one of those sections may not show up on your lab exam. Because I do still encourage you to watch those videos, like the different dissections, and kind of understand what you would have done in those different experiments had you taken this course in person. Okay. Um, all right, guys. With that, let me know if you need anything. If not, I will see all of you in a couple of weeks for your in-person exams. Until then, take care and enjoy the rest of A&P because we're almost finished. All right. Bye, guys.